Okay, thank you very much. I was really honoured to be asked to come and speak today, so thank you so much, TOFS, for asking me to come and speak today. It's a real pleasure. So yes, I'm Julia Faulkner. I'm a paediatric dietitian, and 4 years ago my TOF story began when I had my boy Alex, who we found out at birth was born with TOF OA. So hopefully I can help share some of my knowledge. So today, for the outline of the talk, we're going to briefly discuss TOF issues that are relevant to weaning, move on to talking about starting solids and progressing through the textures, the toddler years, coping with the toddler years, moving into early years settings, so nursery and preschool, and then starting school. Okay, so briefly going over TOF issues. So the first thing to do is following if they may have dysphagia. So this just basically is a posh word for difficulty swallowing. So they may have some uncoordinated swallow. They can also suffer with esophageal dysmotility. In fact, over 75% of children are reported to suffer with esophageal dysmotility post-repair. What this actually means is that either there's no coordination of the esophagus pushing food down into the stomach, or there's a discoordinated pushing of food down into the stomach. So it's helpful to think of food moving down into the stomach as that it's a process of gravity rather than the esophagus working properly. And if you think about this with weaning, it really helps you think about how it is for them moving food down into their stomach. Another complication can be strictures. So stricture is normally a ring of scar tissue formed at the join, and this can occur a few weeks to a few months after the repair. How it would present is your child might slow down their feeding, start coughing with feeding, struggling with feeding, bringing food back while they're trying to feed. Stricture can also be worse when there's reflux as well, because that can scar up the tissue. Reflux is also very common. So this is when stomach contents washes back up into the esophagus. And again, all these symptoms are very similar. So reflux, you would also notice they might be sick during feeds, sick straight after feeds, coughing with feeds, also crying during feeds, crying after feeds, back arching. Yes, and reflux, if it's uncontrolled, can also lead to respiratory issues, so it's important that it's managed. And then food bolus obstructions, or as us TOF people refer to them, stickies. So this is when food might get stuck in the esophagus. It could be a sign of a stricture, or it could just be due to esophageal dysmotility. So you can get a partial blockage. So this is where a bit of food may be stuck, but they can actually drink and get fluids past it. So if that's the case, they will be coughing and bringing up food, but they'll be able to keep drinks down. So you just keep offering drinks to help push the bit that is stuck down. If they're old enough, fizzy drinks are really helpful at pushing stuff down. The more scary one is where they're completely obstructed and they actually can't manage their own secretions, so they're bringing back all the saliva, they're coughing up, and sometimes it's quite thick and stringy. So you do your normal procedure as if they were having a choke, back slapping, and hope that they can cough and bring it up. So when to start solids? So the Scientific Advisory Committee on Nutrition actually this year did a big review of weaning, and the conclusion was to stick the same. So 6 months is the age for term infants generally to start weaning. For preterm infants, because a significant proportion of TOF OA babies will be born early, that's before 37 weeks, 4 to 6 months corrected age, so 4 to 6 months after the date at which they were due is around the time to start weaning. But again, with our TOF babies, it may be different. It may be that you're advised to go earlier, or it may be that you can't wean until a lot later because they've got swallowing issues. So it would be as guided by your medical team, your surgeon, your speech and language therapist, or dietitian. A separate note as well on food allergy, because this is quite new with the latest weaning guidelines. So if your child prior to weaning already has a food allergy, say they have a cow's milk allergy, or they have severe eczema, there is different advice about weaning them. So this is taken from the British Society for Allergy and Clinical Immunology. So if you go on their website, on the link below, there's some guidance for parents and there's some guidance for healthcare professionals. So I would encourage you to print that off and take that when you go and see your paediatrician, your surgeon, and discuss weaning, because in some cases it may be beneficial to wean early, but obviously that's taken in the whole picture of what's going on with their TOF problems as well, so it's all a balance. So signs they're ready to start weaning. So they need to have sufficient head control. They need to be able to be in a sitting position with support. And they should be showing an interest in you eating and actually starting to put hands and toys in their mouth and chomping down on them. And this is new in weaning. So we now know that there's no evidence to support delaying the introduction of potential allergens. So it's important to get in fairly early in the weaning process: egg, peanut, cow's milk, soya, fish, etc. So for a TOF parent, the idea of giving egg or peanut early is like... So peanut, we would be talking about smooth peanut butter, but to make it TOF friendly, you'd mix it with some boiling water to thin it down, and then you can stir it into one of their purees so you can get the peanut in. You can also get peanut flour in the supermarkets as well, so you can stir in a teaspoon of peanut flour into their weaning foods to get peanut in early. Well-cooked egg, again, that's another quite a sticky, stodgy food. So to get that in, and my husband thought this was absolutely disgusting, I used to puree up boiled egg or scrambled egg and mix it in with yoghurt. Because they don't know any different. So then you've got your... You've got your egg protein in, but also you might do it through commercial products. So some of the commercial weaning products will have egg within them as well, but we want to get these in early. And again, as we just mentioned on the previous slide, if there's suspected food allergy or eczema, speak to paediatrician or dietitian. So what to start with? So if you think about the texture your baby's already able to manage, so for most babies, that's probably just that they might be breastfeeding or normal formula, or if you're already under a speech and language therapist, you might have been advised to do slightly thickened breast milk or thickened formula. So if you're under a speech and language therapist, you speak to them and consult with them about what they recommend to start with when weaning. But generally, it would be something a bit thicker than what they're currently managing. So in the case of someone on breast milk or formula, just a thin puree and smooth puree. It's really important to get in a range of tastes. So babies naturally like sweet taste. Breast milk's quite sweet. So if you don't get the bitter taste in early, you can have problems with fussy eaters later on. So you're very much training their palate. Okay, first solid. So this is... I'm going to apologise for this before I put it on. When I filmed these clips, I wasn't thinking I was going to be standing in front of the TOFS conference showing pictures of me and my baby, so I am in my dressing gown. But this is an example of first solid. So it's some puree I've made really thin. It's strawberries I've pureed down. I've actually sieved them as well, so there's no seeds or anything in them. So let's... see, is that working? But you see there, so that's a nice, smooth, quite runny puree. He's doing a bit of spitting it forwards as he's taking it. That's completely normal. Once you start weaning, you're learning how to move your tongue back and move the food back and down. So it's quite normal for them to look as though they're pushing the food out, because when you breast or bottle feed, you push your tongue forward to latch on and suck. So they're just learning how to move food back to the back of their mouth. So... okay, so you can hear a little bit, so it's mainly my husband going. But so he's not making any noise at all, Alex. He's just taking the food in, and yes, some's coming forward, but he's quite happy to accept more, so he seems to be enjoying it. So moving from my family videos. So once you've established on thin purees, and going back to what we said at the start about the esophagus not working properly and things mainly moving down by gravity, then you can think how important it is that they're able to take sips of fluids to help food move down as you move on to thicker purees. So I was really keen to get this established early on. So this is unfortunately a video when he was older, but it's just showing the importance of drinking, and notice the different noises. No, you don't want any more? Okay. Initially, initially I tried dutifully using my free flow beaker to get him to drink, so that's one where the drink flows out easily. But I realised that he, although I thought he was drinking, he was conning me. He just liked having the end in his mouth and wasn't actually taking any drinks. So quite quickly we're like, right, no lidded beakers, we're on to open cups, so that I can tell that you are drinking and I know that you're drinking to help the food go down. Okay, so I'm not going to read through these slides, there's lots of information on them. This is actually taken from a Chew article that a weaning article that I did for Chew a little while ago. It's just so that you've got all the information there in the handouts. So we're talking about once you've done your thin purees, you've progressed onto thicker purees, then you'd be moving on to mashed foods, foods with small soft lumps, bite dissolved finger foods. I have actually got a table out there with some products on. It's not someone's shopping, it's my little display. So I can talk through anything out there with people in the foyer later. So potential issues. So I think as TOF parents, we become really focused on feeding and we become really good at watching our baby's cues for what's going on. So this is just a clip, which I filmed before we were going in for planned dilatation because he was sounding a bit wheezy. And although to me, it seemed like he was okay, you know, you just want a medical professional to go, yeah, that's absolutely fine, carry on. So it's really handy having phones and things where you can record stuff to annoy surgeons and people. So here we go. So that's mashed carrot. You can hear he's a little bit growly. And he seems to be taking it.
Well, some of that's definitely gone down, isn't it?
Famous last words. Because then here you see he was refusing that spoon, his head goes down, he's starting to struggle, he's going a bit red. He's trying to sort out something here, push it down, and then he's coughing to clear it. So,
okay, good boy.
So obviously then we'd stop when they're doing things like that, but we become very good at reacting to our children and stopping and then reporting all these issues to our team. So responsive feeding is important in weaning. So when they're moving their head towards the food, trying to get the food off you, pointing to it, getting really excited, you know, they're hungry, they want to eat. Generally signs that they're full, or for our TOF babies, signs that they're having an issue will be that they will slow down with their eating, they'll start pushing food away, turning their head and clenching their mouth shut. So for our children it could be, hang on a minute, I'm struggling here, or it could be, I'm hungry, I want some more. So it's our job, unfortunately, to work out what they're trying to say. This is my favourite video clip. So this is just all about feeding cues and part of what babies do and them asking you to feed them and the noise. So he's staring at me, getting something ready. He's mouthing, come on. Come on, why are you taking so long? And he's messy. It's really important to let them get messy as well. I still haven't produced this yogurt yet. There we go. So he's having a go at playing with it himself, and then I'm feeding him as well. But it's actually important to let them get messy. Come on, Mum. Poor child. And then suddenly I've produced a spoon. I think I'm videoing at the same time. That's probably why it's so slow. But yeah, it's important to let them get messy actually with eating as well, any child during weaning, because it means they're more likely to encourage them to self-feed early and not have problems moving on with textures and things because they're happy to play with things, touch things and get messy. Where children are cleaned all the time, they then get used to being clean and they don't like touching wet foods, messy things, and you can get restricted picky eaters later on, so it's really important with anyone weaning. But I was also recording this for the noise. So obviously that's a normal noise. That was him excited, being able to make that noise. So this I'd actually videoed for nursery, for when he started nursery, to show them like this is completely normal. Because for them, they will probably never have seen anything like this. And yeah, so yeah. More about moving on with textures. Again, I don't want to fill up my talk with that because it's all there on the slide, and you can talk to me outside if you want to more about that. A bit more again, so basically making harder foods easier. So you can grate things like raw carrots, you can chop things really finely, or I used to use it as an excuse to buy gadgets. I've got a mandolin. Slow cooked, pressure cooked meats in stews, they're really good because they fall apart easy. And cutting meat across the grain so that when it falls apart, it's not in long strings, it's in small pieces. The dark meat in chicken is actually really good because it's moister rather than the chicken breast. So it's moister, so it's easier to swallow. And because it's a dark meat, it's actually got more iron in it, so it's better for them that way. And this might just be my cooking, but bolognese, shepherd's pie, cooking with mince, sometimes it goes a bit lumpy. So a bit of a blitz with the blender so that it is smooth with bits in so that it's easy for them to get down. And doughy foods are the trickiest, such as white bread. So it's easier to start with the brown breads and actually start with them toasted and then work your way through as illustrated there. The toddler years, I found this really hard. They're becoming independent, they're quite willful. It's quite normal anyway for toddlers to go through what we call a neophobic phase, which is where foods that they used to manage, they're suddenly like, no, I'm not eating that anymore. And they're also frustrating for TOF parents start to refuse drinks, which, as we know, is really important to help food move down. So I've been sat there at the meal table with my son, and he's shoving a lane of food in, and then you can hear him growling, struggling, and you're, please have a drink, no. So I'm sat there with a large glass of water myself, having frequent drinks, discussing how it really helps my food go down, just to make me feel better, but hoping that he will then learn by copying me. So interestingly, it was more difficult for me, but at nursery, when they tell him to drink, he'll do it. So they're likely to be at their worst behaved with you. So that should give you some confidence when you're not with them. And then errors I've made is when he's got over hungry and he's shoveled food in really quickly and not chewed it and then got it stuck. And it's so frustrating because one, he's screaming because he's hungry, he just wants to eat more even though he's got stuff stuck. And two, he's screaming because he's got stuff stuck. So to try and avoid that, if you think they might be really hungry, then offer them like a glass of milk or a yogurt, something that you know is really easy for them to eat before their main meal, so they can then slow down, concentrate, chew, and take their time. Also being tired. So if you've got a suspicion they're really tired, they're probably not going to chew properly and might get stuff stuck again. So again, offer easy foods if you feel they're tired. And then you just have random days where for no reason at all, just get everything stuck. You're like, oh my goodness. And you then have to logically think through like, what is going on. So the previous day, were they able to manage everything as normal? Yes, okay, so this can't be a stricture because it doesn't just stricture up overnight. It's a gradual decline in their feeding. So for some reason, random days, you can just have days where you seem to get everything stuck. So I just keep a stock of nice, easy foods that you know are easy for them to manage in. So things like soups, milkshakes, and you can get the ones that are fortified with iron, things, spaghetti hoops, we always found easy yogurts. So anything like that, keep in for those unexplained days. And try and take time for yourself. We need to look after ourselves so we can be strong for our little people, so that's really important. So tips for starting nursery and preschool. So you may have a choice of nurseries, you may have one in mind, but just visit good to get your faith in them. And they should offer stay in place sessions. I'd make use of those, go along to those, so you spend time in the setting with your child, get used to it, get used to the people there. Take along the TOFS leaflets, they're really useful for the nursery staff to take away and read. And then I drew up just a personal statement particular issues that Alex had. And the person most involved in my care at that time, who I had access to easily, was actually my health visitor. So she was helpful and signed my personal statement for me, verifying that this was the case. And it is actually in their statutory requirements, the early years framework, that they must record and act on information from parents or carers about a child's dietary needs. So it's our job to explain to them what the needs are. So Alex went to nursery at about 10 months of age. So under 2 years, there was no additional support. I don't really understand how early years funding works, but then over 2 years, we were able to, he was referred to the area Senko, and she got one-to-one funding agreed for him for meal and snack times, because he did need constant reminding to chew, to have drinks, to stop stuff getting stuck. It may be related to the ratios at early years. So early years, under 2 years, the ratios are 1 adult to 3 children. So actually, at that stage, at nursery, they just made sure that the 1 adult per 3 happened to be sat next to Alex every meal or snack time. And then 2 years, the ratio is one adult to 4 children. And then once they get into preschool, 3 years and above, it's 1 adult to 13. So, yeah. So moving on into the early years setting. So as I said, building up a relationship or trust with the nursery, because often children will behave differently around their peers when you're not there, differently in nursery, and they may be more willing to try different foods and stuff with them. So talking in my professional background in general clinic, fussy eaters I see in general clinic are often more likely to try things in a nursery setting around their peers, and you want to encourage that. So you want a really good relationship with the nursery so that they understand what would be the best way to present things for your child, the safest ways, so that your child can try and experience different foods in that setting. So in my case, my child moved on a lot more actually at nursery, because he would try stuff there, but I gave them advice on the safest way to do it, so cut things up small, things like that. Yeah. And then starting school. So in Somerset, there's something called the PIMS team. So this is Physical Impairment and Medical Support Team. So because we were under a Senko in the nursery setting, we then got referred to this PIMS team. And they are the people that liaise with the school about a medical care plan for your child's needs and make sure that the school are able to meet the demands of the medical care plan. So these people I found really helpful, because they gave me the confidence to go and speak to school even before I applied, because you don't really want to be labelled as like one of those parents. So I actually met with the head and the Senko at the school before I even applied for a place there, and again handed out loads of the TOFS resources, that's really helpful for them to read. And then discussed about meal snack times, and also if you're going to be using after school clubs or wraparound care breakfast clubs, you want to know that the staff covering all of these clubs know about your child and their condition, not just the lunchtime supervisors. And the school were really lovely, really helpful, so I asked if I could go along at a lunchtime just to observe, so I could see for myself what would happen, what would be the process, and be prepared if there was any things I thought might be specifically difficult for my child. So at my son's school, it's quite nice. They all take a water bottle to school, and they actually move that, goes with them through the school. So they go from their classroom to lunch, and they've got their water bottle. So it's great to know simple things like that. I knew he had access to drinks all the way through the day, especially when he was eating. So then drawing up a individual healthcare plan. So it's perfectly acceptable for you to draft an individual healthcare plan, but you also obviously need a healthcare professional to sign it off as well. So there is an example of an individual healthcare plan which is going up on the TOFS website, so that you can look at it and you can adapt it, because it's we know all our children are very individual. Some children have certain foods that are particularly difficult for them, so you can adapt it for your child and have it ready for school. This link at the bottom is just a link to a document about what schools have to do to support children at school with medical conditions. So I think the main benefit for me in having an individual healthcare plan was that I was most worried that my child can sometimes get reflux and vomit, and I didn't want a 48-hour exclusion every time he has a vomit. So that is in his healthcare plan. So if he has one vomit, it's not infectious, it's probably reflux. Please don't exclude him for 48 hours. He's okay to come into school. And then I'm right on time. So it does get easier. I think the early years are really hard. I particularly found the toddler years really difficult when they know better, seemingly. But yeah, it does get easier. Anyone any questions? Thank you.
Julia, thank you for a brilliant presentation. That was really good.
Thank you.
I particularly like the videos.
Yeah.
Let's have questions from the floor. Yeah, we've got a couple of questions over there.
We've just started weaning our daughter. She's nearly 6 months, literally 2 days ago. And it's a terrifying, horrible experience. But luckily, we started in our salt appointment, which we're quite sort of pleased with doing that. The drinking thing for me is a big concern because we tried her with thickened fluids and I think they felt she's better without.
Okay.
But she's having trouble. She's quite good with her bottle and we're fine with that. But obviously she can't be on a bottle forever. And they were say in sort of the literature that they should start experimenting, you know, with more kind of older like drinking equipment. Is there anything you particularly recommend, like just any open cup, or we've tried a sippy cup by Nuck, and she just bites it. She doesn't actually take anything from it. So I just wondered what you thought about that.
Probably the key to it is if you're already under a speech and language therapist, they can look at, is it daughter, did you say, sorry?
Yes,
your daughter drinking and advise specifically for your daughter what is easiest to manage. But there are various kind of open cups you can try. So there's one called a flexi cup, which I meant to bring samples of cups along to put on my display, but I forgot. But I can put together some pictures which maybe can go on the website actually of different cups. So it's called a flexi cup, and what it means is it's flexible. So a bit like a thin kind of plastic cup, but it's also a cross between that and a doily cup. Have you seen those angled ones?
Yes,
So it's like that, but it's soft. So you can bend it to the size of your daughter's mouth and then tip it slowly and watch her drinking.
See how she goes.
But if you've got speech and language therapy appointments coming up,
I'll take one with
you and get them to help you what is the best way for her to get drinks in. But those flexi cups, those doily cups, the angled ones, but they're harder plastic, to try those so they can have their hands on it and you put your hands over the top and guide it. There's also small cups, they look like shot glasses, but they're actually
got some of them.
They're actually like baby weaning cups. They're just small versions of plastic cups that you might have for picnics. So I'm saying this so that anybody can hear, not specifically your daughter, but so any small open cups, have a go with.
Okay, and just really quickly, the other thing was if she does get a sticky, because obviously I don't know what that's going to exactly look like, would she be able to still drink from a bottle? I don't know if anyone knows, like, so if she was struggling or panicking, like when we start textures in about a month, and I just gave her bottle because she's comfortable with that, are they still able to drink out of a bottle?
If she's partially obstructed, and then she may be able to take it. But if not, you'll know because she'll cough straight away and you'll be able to manage
just comes back,
So if anyone's worried, the Red Cross has a great video, or St John's Ambulance has a great video on the website of how to deal with a choke. And the important things for TOFs is for us to calm down and remember it's their esophagus, it's not their trachea, they're still breathing. So we do the back slaps, but if that doesn't work, not to panic, because sometimes I know with my son it was just a passage of time, so just sit with him, try and calm him down, and after a few hours it would go down.
Thank you so much.
That's okay, thank you.
There's another question at the back.
Mine's not a question because my TOF's 17 and she's over there, so she eats fine now. Mine's more a bit of advice. You talked about having gadgets. The two things that we found really invaluable were a potato ricer, which looks like a giant garlic press, and also a mouli, which is like a sieve, slightly more robust, and it has a rotating blade in the middle which pushes the food through. Don't make the same mistake that we do. Stick blenders are perfect, but you'll always miss a bit at the bottom. So the 2 times we landed up in hospital having to have stickies or bolus obstructions removed were bits that I'd missed with a stick blender because I'd been a bit slapdash. So please, please, please buy yourself these things, because you know then, it takes a little bit of extra time, but you know then if it's gone through those fine holes of a ricer, a muli, or just an ordinary sieve, then it's not going to cause that obstruction, unless of course it just punches up or they've got a sticky, and then you can't really do much about that. But try to avoid those pitfalls that I fell into. Thank you.
Yeah, we've got another question just there.
My son's CVH is yours 4. We're just wondering what support you expect him to receive from dietitians and consultants, because we're getting nothing from our local health. We're getting nothing from our local health authority. He hasn't had dietitian input for 2 years, and salts, not since the beginning of the year, and they've told us they plan to discharge him, as are the paediatric unit as well.
Oh, they have.
So they have. So we're just wondering what support we should be getting so we can challenge them about that.
Okay, definitely don't get discharged from medical care, and I'm sure that will come up later anyway. But you can ask your GP to re-refer to the dietitian, specifically if there's special problems, like he has got restricted diet, you're worried about the nutritional adequacy of his diet, then you know you need an assessment to cover that. But like for instance, my son, obviously we haven't needed, I did get a dietitian referral once, but quickly discharged. But if I wasn't his mum, he wouldn't need a dietitian at the moment, so not everybody will. But if you're worried about nutritional adequacy, then yeah, ask the GP to refer to a dietitian. And the same with speech and language. If there aren't any active swallow problems now, because he's older, then, but if you are worried, they're struggling, then ask for a referral.
I think it's more a question of how do we move on with his eating. Primarily his diet is pureed. He can eat some more solid stuff when he does.
Yeah.
But his diet is by no means normal for a child of that age, and we just haven't getting no guidance at all from our
Okay, so if for some reason they've discharged you, ask for re-referral, because they should work with you through those things to help. Yeah. Some areas have specialist feeding clinics as well that you might get referred to. Or if you're not getting anywhere, ask for a second opinion somewhere. But yeah, ask for re-referral.
Just got a quick comment from Mr. Lander.
Hi, yes. My name's Tony Lander. I'm a paediatric surgeon in Birmingham. I think that that's terrible that you're then struggling to get support from speech and language therapy. One of the problems can be that lots of the speech and language therapists, because esophageal atresia is not that common, lots of the speech and language therapists haven't had to deal with the dysphagia. But I think that there are those who do have that expertise. And I think that the route should be, rather than necessarily having to go through your GP, but to go back to the primary surgeon and the surgical team and say, because they will have had this problem before. Certainly lots of my patients have had dysphagia afterwards. Maybe the other surgeons generally don't have dysphagia in their patients, but mine certainly do. And so then I ask our speech and language therapists in our tertiary centre for them to direct to the right people. And you shouldn't be struggling. If you're struggling, it's back to the primary surgeon and through their secretary to get re-seen again and referred on. I understand that. I understand it's not an easy problem, and I understand I've certainly had the problem that I've asked the speech and language therapists to help, and they've said, oh, it's the local team. But if you want somebody behind it to do the pushing, which might well be needed, it's just it's persistence through that route, I think, because the GP could struggle. I mean, you can try both.
Thank you. Thank you.
I agree with what Tony's just said completely. Any other questions? Yeah.
Just a really quick one. We were speaking to a mum, earlier about around the 20-month to 2 years kind of age, we seem to be experiencing more stickies when before we've had a real good period of them doing fantastically and food that they would ordinarily cope with. And I know there's some sort of guidance and advice that it's about perhaps growth of the esophagus and things. Did you have that, and how did you overcome that? How do you know that that's just a growth thing or whether there's something else going on? Because obviously that's just something that we're going into now.
Yeah, I mean, you definitely
and
need to bring it up with your surgical teams, because it may be they need to check it out. Is something else going on?
Well, I think it's what you said. It's so ad hoc and random
Yeah.
that you would eliminate stricture.
Yeah.
But it's definitely increasing to, say, 3-4 months previously. There's definitely a period of time now where he seems to be struggling more. And I didn't know if you had any experience of that or advice on that, it being an age thing or...
No, I had random days where it was seemingly unexplained, but if you've noticed a pattern where it seems to be a few more episodes, I would definitely mention it to your surgical team, because it may be something that they, not necessarily a stricture, it might be something else, it might be the reflux is causing a problem, but you definitely need to speak to them. It can just be where they're being toddlers and not chewing stuff as well, because they're just like, I know how to do this, and and they shovel stuff in. So I've had to regress some stages sometimes and go back to really small pieces of pasta, whereas previously I would let him eat penne pasta because he would chew it sensibly. But if they're just being toddlers and being a bit more independent and shoveling it down.
I think that's the difficulty. It's definitely happening, but it's so random. It's at what point
Yeah.
do you go, okay, well, we need more help on it, or do we just keep riding it because it might be...
I'd always mention it to the team in case there's, and then once you've discussed it with them, then, you know, well, you'd have to regress a bit to cope with it at that stage, but definitely mention it to the team in case there's anything else going on. And unfortunately, that is what it's like. Yeah.
Thank you very much. I just want to make one final comment. I'm not going to make many comments, but this is one final comment. Please don't feed your children in the car.
Yeah.
Thank you very much.
Thank you.
That was great.